Hello everyone, myself Dr. Sunil Kumar. I am diabetologist and medical superintendent in Yatharth Super Specialty Hospital, Greater Noida. Today we are going to discuss a very interesting case. A few days ago, a middle-aged female, she is having a history of type 2 diabetes since last 2 years, visited to my OPD, and the main part was there that she had frequent hypoglycemic events in last 2 months. So 50-year-old female with type 2 diabetes since 2 years with frequent hypoglycemia. In last 2 months, more than 2 or 3 episode was there. On physical examination, when I gone, so we found that her BP is very well controlled. 120 by 70 was the BP, and heart rate was 78 per minute. But she had a high risk of cardiovascular diseases. Her BMI was 31, which it means she was obesity. Further, I investigated her. We go for laboratory findings, and her HbA1c comes out to be 8.2, which is absolutely not the target what we needed. On further investigation, we do the lipid profile, and in lipid profile, it shows that LDL was on little upper limit side, and HDL, which is considered as a good cholesterol, is on lower side. LDL was 90 milligram per deciliter, and HDL is nearby 36 milligram per deciliter, whereas triglyceride was in normal range. And when we go for her kidney function test, creatinine was 1.1, but significantly when we calculate her eGFR, which is comes to be on lower side, 88 ml per minute. LFT was quite normal. AST is nearby little on upper side, 33 IU per liter. So whenever such patients came to our OPD with recurrent hypoglycemia type 2 since the last 2 years, and just middle age in the age, and when I go her medication, she was on 1 gram of metformin twice a day, and sulfonylurea 2 mg twice a day she was already on taking. So for such patient, first thing came in our mind, how we can optimize her glycemic control with providing her, because she is a risk factor of cardiovascular and renal disease, with the best protection of cardio-renal protection, and optimizing her glycemic control with the reduction of HbA1c approximately 1 to 1.5, because we all know that 6.5 to 7 is our optimal target. And as we know about the diabetes in the 21st century, type 2 diabetes has reached epidemic proportions globally, and especially in India, there is a high tendency of type 2 diabetes in early ages, and along with its complications also there. So now if we'll see this case study here came in our mind, we should go for strict glycemic control without having a hypoglycemic event. As we all know, sulfonylurea play very good role in glycemic control, but whereas it is a very high potent of causing the hypoglycemia. And along with the metformin combination, she was already taken. So that sulfonylurea was the major culprit which is causing this hypoglycemia. So here two treatment options came in our mind. First, either with 8.2 HbA1c with high cardiac and renal comorbid risk, either we go for insulin therapy or we go for tetra or third combination therapy. But as we see that maximum Indian population is not so good with the injections with the insulin, because multiple times they need to take, and especially the preservation of the insulin, the cold temperature and cold chain maintenance, and it's always tough. And usually the Indian population and our Indian patients usually not prefer to scenario. Further, best therapy for controlling her glycemic control as well as protecting her from the cardiovascular point and renal point came in our mind is the combination of DPP4 inhibitor and SGLT2 inhibitor. There is a strong rationale for combining a DPP4 inhibitor with the cardiovascular protection class of SGLT2 inhibitor in such type 2 patients. Furthermore, this combination is increase of glucagon level induced by SGLT2 inhibitor may be blunted by the co-administration of DPP-4 inhibitor. Clinical evidence shows that SGLT2 inhibitor and DPP-4 inhibitor combination is an effective option of management of type 2 diabetes, providing HbA1c reduction to 1.1 to 1.5% and approximately weight reduction of 2 kg. So as she was on high obesity range, BMI was on 31. So weight reduction with this class will added an extra advantage for choosing this combination. Along with when we added a metformin, which is primary place in the therapy. American Diabetes Association recommend initial combination therapy should be considered in the patient who is presenting with HbA1c above 1.5 to 2% of the target consideration. It means 6.5 to 7 is our target to achieve it, and more than 8 is, and always considering as per the American ADA guideline also, we should go for this combination therapy either with SGLT2 inhibitor and DPP4 inhibitor. And this is a good thing that with oral medication, this is a bridge between the insulin therapy and go for this combination therapy between insulin and metformin and sulfonylurea. This is a new treatment option always in our mind. This unique combination lends itself readily to early treatment intensification because of good tolerability, low risk of hypoglycemia, possible weight loss, and minimal treatment burden to the patients. Clinical experience with DPP4 and SGLT2 combination shows that they can be used with a good safety profile and a low risk of adverse events like hypoglycemia and weight gain. Even when added to the metformin, which is a particularly important finding for all the clinicians. A reduction in the incidence of genital infection like UTI with the whenever add SGLT2 inhibitor with the DPP4 inhibitor, there is a significant low incidence of having genital infection or UTI to the patient. So it's always a better choice to go for SGLT2 inhibitor and DPP4 inhibitor combination when there is high risk of cardiovascular risk and renal comorbidities are there with type 2 diabetes, with obesity, where lipid profile is not well controlled and patient is not willing to take an insulin therapy. So this class of DPP4 inhibitor and SGLT2 inhibitor give a added advantage to the all clinician and diabetologist for oral medication class. Thank you.